Have you ever wondered what the top esters are? What's the best ester to use for testosterone replacement therapy? There are many different esters available, everything from testosterone Cypionate, testosterone Enanthate, testosterone Undecanoate, and a blend of esters that make up Sustanon, which is a combination of testosterone propionate, some medium-acting esters, and longer-lasting esters. So we're here today in Miami with Dr. George Tsiliatos. We haven't seen Dr. George for a while on the channel. We've been traveling. We're at the Mr. Olympia in Orlando, and we're here in Miami to discuss what are the best esters. Is there a best ester to use when you're on TRT? So hi, George. Good to see you in our first podcast in a while together.
Yeah. We've been shooting last year in Vegas, and we recently filmed in Orlando for the Mr. Olympia and the Olympia University. You're the main sponsor.
That's right.
So here we're now in Miami, and we're international. So speaking about the esters, we have the fast-acting esters, which is the propionate, but actually there's also the water-based that's rarely used. The suspension has no ester and actually has 24 hours half-life.
For the water-based, but that's not really commonly available at pharmacies, and no one uses it for TRT.
So by resembles a cream, so it comes off the system on a daily basis. So we have the injectable, we have...
before we go into those, let's talk about the testosterone propionate.
Propionate, yes, so every 48 hours or 3 times a week.
Okay.
Then we have...
And which dose of the testosterone propionate?
Which?
So there's different doses you can use. So in Europe and in the UK, we have available testosterone propionate that comes in 25 milligrams per 1 ml in a single-use ampule.
I would say if you use 25 milligrams, you're going to use it every other day. So 100 per week, let's say, every other day.
Between 75 and 100 per week and every other day.
Yeah, exactly. Then we have the enanthate, which is actually, the propionate releases 80% of the ester, the enanthate 70%, 71%, and the cypionate 68%. So the half-life of the propionates is around 2 to 3 days.
One of the things, just before going to the enanthate, about the testosterone propionate that we found very interesting is in some patients who have used testosterone propionate at 25 milligrams every other day, they're seeing really normalized hematocrit and hemoglobin.
Yeah, that's what I say. Now, the half-life of the ester has to do with the microdose. So the only appropriate for microdosing actually is the cream and the propionate.
Because
you cannot microdose enanthate or cypionate properly because they have 5 and 7 days respectively half-life. So before you clean the system, you inject in another one, so they accumulate. So only propionate is ideal for microdosing, strictly speaking, because as clear the system, then they inject the next dose.
Okay, so there is a study that talks about, and this is getting back to why some people would use the propionate, the elevation of hematocrit and hemoglobin seems to be less.
Yes, because it spikes less.
Because you're getting a lower trough level as well. So the trough level of free testosterone seems to be a predictor of elevations of hematocrit and hemoglobin.
So that's why it's more important to have a lesser spike in the free testosterone rather than the total testosterone, because the free testosterone is the one that works, the real deal. And if it spikes, it's over the range, then more likely you're going to have...
On trough, if it's over the range on trough.
Yeah, the trough levels, if they spike, if they are over the range, then most likely you're going to have excessive estrogen and DHT boost that will lead to erythrocytosis, hemoglobin synthesis.
Okay, so have you seen testosterone propionate used in other ways? Have you seen 25 milligrams daily? Have you seen...
in bottles it comes in 100.
It does come in 100 in 2 ml.
So let's say 0.1, it is 10 milligrams, all right? If you do it microdose with an insulin syringe.
But you don't recommend...
But usually it's in Italy comes 2 ml at 100.
100 milligrams in 2 mLs, and it also comes 25 milligrams per 1 ml. And at the Hormonist pharmacy, we supply 25 milligrams in 1 ml.
That's perfect.
Because it's exactly...
If I had access to their Hormonist, I would use propionate on a daily basis.
Yeah, would you? Okay,
absolutely.
So there are some benefits, and I considered it as well. I just don't want to inject as frequently. So the next ester would be testosterone, let's say, Cypionate.
Cypionate is widely used in the US. It's a bit slower than the enanthate, and it's perfectly to be used once a week.
Okay.
That's the perfect
What
range.
dose once a week?
I would say 200. Well, you're gonna spike with 200
Okay.
in one dose.
We can also go with 100 once per week. You can get
Yeah, Connor
100,
does
100 every 5
Thomas
days.
Connor does 100 every 5 days.
Yeah.
I would say you can do, let's say, every Monday now, 100, 150 or 200.
Okay, so what there are, I guess it depends on the right ester for the right person, right? Some patients don't want to inject that frequently. Other patients prefer having it set on one exact day per week, and they know that day. Other people are better using the calendar, and they set the calendar to do every 4 days, every 5 days, every 6 days, every 7 days. I think it just depends. So, have you seen a difference between testosterone cypionate and the next ester, which is testosterone enanthate?
No, they're very similar.
Yeah, they're usually interchangeable, aren't they?
Enanthate is a little bit faster, okay?
Absorb more quickly. So, do you think it gives you a bit more of a spike or a peak, or it's quite the same?
Very similar, but in Greece we have enanthate. All I'm using is enanthate.
Okay.
Pharma grade. Yeah, and then we have the undecanoate, which is very slow, 60%.
So undecanoate is known as
The libido.
libido.
Yeah, it's around to be used every 2 or 2.5 months, 8 weeks, 10 weeks.
Yeah.
No, the longest
12 weeks.
is 12 months or 3 months, 12 weeks or 3 months.
So with undecanoate, we're talking it's a whole 1,000 milligrams in one go.
Yeah, this is a major
4 mils.
disadvantage for spiking the hematocrit, but also the estrogen. So you get super high the first month, it kicks around second, third week, and then right before injecting again the trough level at the 12th week, it's around 300. So you don't have a steady.
So this is the argument.
Spikes and then it troughs, and you don't feel well before the next injection. So you should bring it sooner, all right, around from 12th week to 8th week.
And this does happen sometimes in clinic. I mean, what amazes me about the undecanoate, libido or Avid in the US is that, it's not that new of a molecule. I mean, it came out undecanoate as was the Andriol
yeah, but surprisingly, Andriol has very fast half-life.
Yeah, it's supposed to work through the lymph. So you would take that, and that was supposed to slow it down. And so suddenly, by the manufacturer adding 4 milliliters or 1,000 milligrams in 4 milliliters, somehow people think this is just going to be amazing. It's going to increase the duration. But if you give, and yes, it has a low startup, right, low ramping up period, and it lasts a lot longer. But I suppose if they used to do 200 milligrams of cypionate every 2 weeks.
Yes, so 125 per week, which is a good dose in order to be below 1,000 nanograms per week. Okay, that's what I'm using every 7 days actually, half cc
of enanthate.
So yes, if you take 1 gram in 2 months, you're gonna have 125 per week.
Okay, so I mean that can work for some. I think it just depends on what they're prescribed.
Yeah.
Sustanon. Let's talk about Sustanon.
Sustanon is a blend.
It's a blend of the different esters.
It has a very fast acting, the propionate, but also a slow acid, the undecanoate. So it enters the system, but it clears the system slowly.
And I think the longest one is the testosterone decanoate. And it doesn't have undecanoate. It's testosterone propionate, phenylpropionate.
Isocaprate.
Isocaprate, and then undecanoate.
Yeah.
So that's.
So you feel the difference fast with injecting. It gets you to the bloodstream.
But it's testosterone propionate of the Sustanon mix is the lowest level. I think it's quite misunderstood. I think in the UK, Australia, other countries throughout the world, the Netherlands, other parts of Europe, there's Sustanon, but there's also Omnadren, which is essentially the same.
And in Poland, yes.
But it's exactly the same formulation now as the Sustanon.
I think there are 3 blends in Omnadren.
4. It's the
4?
same. It's the same exact combination as Sustanon now. So those are the major esters I think I want to talk about. I don't know if anyone's watching this live, but we can, one second, see if there's any questions from anyone else watching. Let's see. We didn't go live. Are we live? I can't see it. Okay, 1 second. Let me see.
You want to put it on Instagram Live also?
No, it's just on YouTube Live. I'm not seeing it on YouTube Live. Are you sure?
We're live. Yeah.
Oh, sorry. Are there any comments or questions that you've seen coming through on the live?
There haven't been any questions yet. At least I don't see any.
All right. Well,
There was 8 viewers so far.
there's what?
8 viewers. There's only one person viewing right now.
Okay. Well, anyway, that's a good start, I think, for the different esters that we. There are 8 viewers, you said.
Yep. Someone just asked, how long does HCG usually take to increase intratesticular testosterone?
That's a good question. So, how long does HCG take to increase intratesticular testosterone?
While on TRT?
Let's say.
Or as opposed to
as a monotherapy. So they just did HCG alone. Now, the experience why HCG isn't used alone.
monotherapy, but it shuts off the LH.
Yeah, it shuts off your LH. So there's really no advantage when you compare it to testosterone, other than you keep your testes going. But it takes a lot more HCG, wouldn't it, to get a similar amount of elevated testosterone levels as would an injectable testosterone. So you can do 100 milligrams every 5 days with testosterone cypionate. It may take, 500 IU of HCG about every other day, maybe to get it close to the levels that you would reach with the injectable testosterone. What do you think?
Well, when we use HCG as a part of the PCT protocols in bodybuilders, we used every 3 days, that's the half-life. And I'm telling them to use 5,000 to 6,000 IUs. And then after 2 weeks, they feel a great kick in libido, in mood, even in strength. So after the second week, they feel the difference.
5,000 to 6,000 IUs
Totally.
total.
Totally.
Divided
so
out
divided
during
5
the
doses
PCT.
or 6 doses of 1,000.
Okay.
So we do kind of a small dose, micro dosing, every 3 days.
About 500 IUs. Every
2,000.
2,000 IUs.
Every 3 days.
Every 3 days.
Yes. And during the second week, they feel the difference.
Okay, so it does bring up but it's a lot of HCG to use.
I wouldn't compare apples with oranges.
Yeah.
I mean, it's like comparing a knife with a gun. I mean, testosterone is the real deal. It cannot be substituted by anything.
Mm-hmm.
Now, if you bring them together, if they join HCG, it's much better also because you don't
TRT.
shut off your own production. Your balls are still alive, and also it's a libido enhancer during TRT because this intratesticular testosterone will give you more sex drive. All right.
Well, not to mention that if you have the cost involved in having testosterone and HCG can sometimes be more, but if it's actually, because you're using a smaller dose of HCG, it's not as cost prohibitive as if you had to use a massive dose of HCG.
I'm doing
all the
actually
time.
100 IUs every day. I break it down as Chrysler used to say, John Chrysler, that mimic your own production of testosterone with small doses of HCG.
I think the one group of people, one type of person that couldn't use HCG would be those who have testicular damage. Right? If you're primary hypogonadism,
or perhaps seminoma, testicular cancer survivors.
yeah, because then there's not a whole lot to produce.
But you believe that in testicular failure in primary hypogonadism, HCG has no benefit?
I think that's very little. If your testes aren't going to take a signal from your LH, which is better, and FSH, why would it do any better with HCG?
So they're not fertile no matter what? They cannot be fertile?
I think it's going to be more difficult, but I mean, I'm sure there's some who have reached that. Any other questions?
Yes. Question, can you read this out?
I heard Nth is more estrogenic than CYP. Is that true?
Which one?
EN.
Enanthate.
Enanthate.
You heard
I don't think
enanthate
so,
is more
no, I don't
estrogenic
think
than
so.
cypionate.
No, actually, it remains in the system 4 days, 5 days, while cypionate 8 days. Therefore, there are more chances of cypionate to aromatize. The opposite. The sooner it clears the system,
they're
like
nearly-
propionate, for instance,
yeah.
it doesn't aromatize.
They're nearly identical.
It's 71 to 68, but if you search out the half-lives, it's 5 days to 8 days.
Okay, horses for courses. I mean, there's not much.
And
in
also
it.
aromatization is up to the dose, okay? Also,
Exactly. How much dose you take in
adipose
one
tissue,
go?
ethanol, soy. Okay. It's
Okay.
multifactorial.
Any other questions?
Not at the moment, no.
Okay. All right. Well, that I guess will conclude our video for what are the differences in the different esters. Hopefully you found this helpful. We don't normally do live, so this is quite a special treat for those who
We
wanted us
did
to do
also
live
in
video.
Orlando. Eh?
And we were in Orlando. Well, that was a mini. That one didn't turn out as well, so we're making up for it with this video. We got another question?
Another question.
All right, good. Another question.
Adam asked, what is the best way to increase estrogen for men with aromatase deficiency?
Okay.
Well, you can use synthetic estrogen. You
Yeah.
can use HCG
Yeah.
because you will aromatize.
Well, probably your first step is try to get, the one thing I've heard from some doctors is just increase the total dose, but there are still some men who may not convert. And we've seen this, it's rare, but we've seen it a few times.
I would add HCG.
You'd add more HCG. And then if that didn't work, a synthetic estrogen
Yeah.
or bioidentical estrogen probably is a cream.
Mm.
And they do make estradiol injections as well, but maybe a little bit of cream to help with that.
And can one incorporate HCG, Clomid?
No Clomid. There's no reason to add Clomid.
Tamoxifen?
Oh, clomiphene. Oh, by the way,
I don't know how
Yeah.
to say that.
Oh,
Christian,
yeah.
can you read
There's
it
no
out?
reason to add Clomid in
no.
the.
But by the
person.
way, just as a disclaimer, that this is for educational purposes, entertainment purposes only. If you do have a medical
Clomiphene
condition,
brings problems because it raises SHBG. It's
Yeah.
counterproductive.
well, yeah, clomiphene.
It works in the paper, but it raises LH.
So
Total testosterone, SHBG, and free testosterone goes down. So it's counterproductive, especially in large doses. Crystal said 12.5. In very low, it may work. But if you increase the dose, you feel lousy. You have retinopathy, blurred vision. And also, it's...
well, the issue with some SERMs like Clomid is you've got it agonizes the estrogen receptor, so it's going to be affecting the liver. You're going to, you're right, raise SHBG. You have some pro-estrogenic effects, and then you're going to have some anti-estrogenic effects in the brain. So, Clomid is a tricky one because not everyone feels
and
better
also
on
they trigger
Clomid.
clotting, the SERMs, huh?
Yeah, and potential clotting with SERMs. Yeah, so it's something that you want to be, for some people, you want to be focusing more on the total exogenous testosterone. A couple of years ago, there was, I think from one of Dr. Mark Gordon's programs for TBI, he is a big proponent of Clomid. Remember Dr. Mark Gordon? So for those who had traumatic brain injury, he was using a clomiphene to help stimulate the brain, plus adding a bit of testosterone into the mix, no more than about 60 milligrams
I
per
would say
week.
HCG is superior to Clomid, to the side effects,
I
and to the efficiency in the testicles.
Well, I think people subjectively feel better with the HCG or exogenous testosterone than they do with Clomid. So actually, before we go on, I don't know if we put the disclaimer because we never did a live video. Normally our disclaimers in our main video, but this is just for informational entertainment purposes. We're not providing medical advice here. And if you have some needs for medical advice, please contact your GP or a doctor specialist. But because we provide some general information, and this is really opinion, just want to let everyone know that since I never did a live video like this before. Anything else?
Yep. Adam asked, does high estrogen increase chances of infertility in men?
The high
Does
estrogen-
high estrogen increase the chance of infertility in men?
Now, usually the high estrogen shut off GnRH for LH.
Yeah.
Okay.
It's part of the feedback loop.
Yes,
So.
yes. And in such case, you have less testosterone that matures the sperm. In 90 people, okay?
Does he mean it in context of
Within TRT
with TRT
or
and
an
HCG or?
Doesn't say, eh?
It doesn't say.
Okay.
Now, in 90 people, this way. Now, in people within replacement therapy, estrogen is beneficial. Okay, we shouldn't block it.
Of course.
He says on TRT.
So you're doing TRT, HCG, and will the increased HCG, which causes increased
I guess
estrogen?
not, because HCG increases estrogen
Yeah.
through the intratesticular testosterone, and HCG improves fertility.
Okay.
I wouldn't say a negative factor of estrogens during the fertility, because this is what HCG does.
Well, as your
Indirectly,
testosterone
indirectly.
increases, estrogen increases.
And they also compound that and said on TRT.
Yes.
Yeah, that's what
We
we just
answered that,
answered,
yeah.
yeah.
I mean, anabolic steroids.
Oh, that's a whole
Anabolic
different kettle
steroids
of fish. then.
suppress fertility, okay?
Yeah.
We know that.
Anything else?
That's all I've got right now.
All right. How many people are watching?
It says you've had 8 concurrent viewers, and I can't see the head count right now.
That's all right.
You have another question that came in.
Okay.
In your experience, which ester is the most optimal for the general population?
It depends on the lifestyle somebody wants to use. Okay, if he wants to do, if you want the perfect microdosing, I would say is the cream,
For doing
the
daily.
lesser spike. Okay. If somebody travels a lot and is not convenient with injections, okay, do it with Undecanoate every 8 weeks. I would
Yeah.
say.
But for the general population, I mean, we've seen in some of the.
If I had propionate in my country, I would use propionate to
Yeah.
avoid the spike and elevate my HCG. Okay.
To elevate your what? Your HCG?
My SHBG.
SHBG.
My SHBG, yes.
Well, I think we see, at least in the UK, quite a large number of patients using Sustanon in varying degrees every 5 days, similar to the Cypionate. And I found personally, when I've switched from Cypionate years ago, when I was in the States, to Sustanon, it was nearly a 1-for-1. But I've done as well as...
Have you tried the Greek Enanthate?
I've tried the Greek Enanthate, I've tried
Do you like
the
it?
different Cypionates. Yeah, they're very comparable. When I didn't have my Sustanon and the Greek Enanthate was there when I was in Greece, I didn't miss a beat. I used the same exact dosage I was doing with Sustanon, with Enanthate. I didn't notice any difference with
The
either of
Cypionate
those.
comes in 200 or 250? I think 200.
Cypionate comes, well, it comes 250, the one of the brands, in an ampule, 250 in 2 mLs of olive oil and ethyl oleate.
Olive oil.
So it's a combination of mostly olive oil and ethyl oleate. And that's made in it. Well, it's licensed in Spain by an Italian company.
I think
It's
the
also
Americans,
it's also made in 100 milligrams in 2 mLs.
Yeah.
But there's a 250, 100 milligrams in 2 mLs. And then from the United States, there's 200 milligrams
1 ml.
in 10 mLs. And there's,
Yeah.
there's 2,000 milligrams in 10 mLs, and there's 1,000 milligrams in 10 mLs. So these are the different options that are available mostly throughout the world. I know there's a few other ones. So what is the optimal one? Similar to dosing, what's going to be best for the individual patient? And I think it's a way up of cost, convenience, what's available in your country. And I think that, for me, I've got a choice between all of them, and Sustanon seems to be one of my favorites with that one. But again, it just depends on what works for most people, and what we've seen is that seems to be working the best, but there are many other options that we have, especially at our pharmacy. Okay.
And can you inject TRT subcutaneous rather than intramuscular?
Yeah, this is an interesting one. So George comes up with a good compromise with this situation. So on paper, and for some people, subcutaneous seems to work well. The question is where and what do they consider subcutaneous? So, the Chrysler, he kind of popularized Dr. John Chrysler. He has this video of him looking quite buff and tanned, and he goes into the fat pad in the stomach. Now, when I was younger, and some of our patients have also tried it, and I've got pictures of people in our Facebook group that sent me the result of them doing the subcutaneous injection. What we've seen are these lumps and bumps and bruises, and the bruises, they last for weeks.
You have to know that the blood supply into the subcutaneous area is much poor.
And that's the other reason, the
it's slowly
absorption.
absorbed the day after, I guess. And also, if you inject, of course, oil into the fat, you create the lumps, especially if you are lean.
So, right, that's not a very nice look.
Unlike the intramuscular, the shallow intramuscular, as Virgil says, into the delts with an estrogen series that goes straight to the bloodstream and is absorbed abruptly.
Well, essentially, yeah, and that's what I love about Dr. George's compromise is that it is a compromise. So for some guys, they're fearful.
It was for the sake of the scar tissue initially by Chrysler.
Yeah, but here's what we've heard from some of the other doctors on our channel is that you still get scar tissue with subcutaneous insulin. If you're injecting over...
To your mind, it doesn't hurt that much.
But you can get subcutaneous scar tissue if you're injecting all the time, even with water-based, not testosterone, even with water-based HCG, growth hormone, peptides.
I have to admit that with HCG that I'm using on a daily basis and GH, I have some lumps.
So there you are. So this thought about...
and you can see this in bodybuilders.
Scar tissue.
When they do the abdominal pose, because they inject insulin into the stomach and GH, they have these lumps because they are very thin, the skin.
And they're creating maybe scar tissue. So where the muscle, if you inject into the muscle, it's got more blood vessels, so less chance of forming scar tissue.
More recuperation, eh?
Yeah, more chance to recuperate, more chance to heal. So that was from Dr. Kathy Smith O'Neill, who's been on the channel. She acknowledged that. So where I love your compromise is this. For those who are afraid of the extra long needle on top of the syringe and all that goes along with it, some people are fearful of that needle, but they're not as fearful of the small subcutaneous injection, or the insulin syringe, which is an all-in-one needle and syringe together.
27 gauge, I think.
Or 27, I think, 27 gauge is quite good because it's large enough to accommodate the oil. So if you do it in a thin, in an area like the quads or the delts, then you're going to essentially do an intramuscular.
You penetrate all the muscle.
Yeah, you're going to do an intramuscular injection, but you're not going to have all the lumps and bumps that you normally get from that subcutaneous injection, especially when guys want to put it right in the abdominal fat. And again, like you said, the other benefit of going intramuscular is one, it says it right on the label. If you ever see Cypionate, testosterone Cypionate, it'll say for intramuscular use only. Right? So why would you put it subcutaneous? If you're afraid of needles, most of the pain is in the is in the initial layers of the skin. Once you get through the skin and into the muscle, most of the hard work's been done already. Most of the pain you've already been through it. So once you can get yourself convinced to go into the muscle, it's not that bad. Now, the degree and how deep you go will depend on whether you use an all-in-one insulin syringe or you use a 23, 25 gauge needle to do the injection. And there are some techniques where you change out the needle and do a smaller needle. So you would maybe withdraw with, if it's an Ampion 18 gauge needle with a filter on it, and then you would swap it out to a 25 gauge needle for the actual injection. So now it's very sharp, or even a 23 gauge needle where it accommodates that really viscous oil and you don't have to push as hard. So you have less pressure there. Anything else?
Yes. Do LH and FSH levels remain elevated after discontinuing SERMs like Clomid or Nolvadex?
Okay, so do the gonadotropins stay elevated after? What have you seen?
Well, the SERMs elevate, they kick the brain, that's why they elevate the LH and FSH. Yep. And afterwards, LH and FSH kick the testicles for the Sertoli and the Leydig. So indirectly they kick the brain, and afterwards they kick the testicles. That's what SERMs do. But
when you discontinue it, it will normalize it.
Yeah, I guess so.
In time, I mean, if you're once that, because essentially the SERMs
I've seen in the paper
the brain. Yeah.
Men that doing the PCT protocol, and right after, the week after, it's still elevated. I've seen LH of 10, for instance.
Right. Oh yeah, I've seen quite high LH and 10, FSH 15, as well.
Yes.
And we've seen some success stories with patients who have used.
Could be temporary. They rise and fall again.
Yeah, and I've seen that before with some patients that had used they
feel good but temporary. After a while, they go down again.
Yeah, it's usually because of the racemic mixture of Clomid, right? So you got the two different
N-clomiphene,
and N-clomiphene, and N-clomiphene is more anti-estrogenic, and the Z-clomiphene is more pro-estrogenic. But the Z-clomiphene lasts longer in the body
than the
N-clomiphene.
Tricks the hypophysis by lowering the estrogens, and then they kick the hypothalamus for generates indirect stimulus.
It would be ideal if there was another substance that did the exact same thing but didn't have all the negative effects. Something that, who knows, through future drug discovery would do the job. I know there's some talk of kisspeptin as a peptide.
But I had a patient, 25-year-old, overweight, I would say obese, 260 pounds, 6'2", with 30% body fat. His total testosterone was 300. He tried kisspeptin, no success story, and then he went to TRT.
Okay, so it depends. Kisspeptin's not available as a pharmaceutical. You know, it depends where the kisspeptin came from. Was it from a reputable source? These are all experimental. They've done studies on kisspeptin, but it's a precursor hormone to launching your GnRH. So some think it helps kickstart puberty, potentially kisspeptin, and maybe kisspeptin has been studied as a possible.
And also the triptorelin, you remember? Triptorelin.
Yeah, but
it's given to
triptorelin,
prostate cancer, basically to castrate, because it's GnRH agonist.
But the dose that they use burns out that
exactly
that axis, which
you
is
have
why
to be very delicate with the dose.
Tiny dose. So, but with the kisspeptin, they've also studied it. There's been some recent studies looking at kisspeptin for improving libido, but again, these are research chemicals only, and there's going to be more data for it to come out, and it needs to be an approved drug, because if it's not an approved drug, you know, you're really risking your health and side effects, because you don't know what other negative effects it's going to have.
I would say the best option is HCG. People feel superb on HCG when I kick the HPTA, but also when you implement into and you join testosterone.
Well, my personal experience with HCG has been I'd use HCG 500 IU 3 times a week, and I had not used HCG for a long time, probably years before that. I did a semen analysis. I've said this before. I had 156 million sperm, 72% motility after TRT and HCG together. Of course, we've also seen patients who had bad fertility before they started. They did TRT with HCG, and they can barely get theirs up towards 5 to 10 million sperm. So it really depends. If you come into it and you have infertility to begin with, you can't always expect miracles. But if there's no damage to your testes, then there's no reason why you wouldn't get a good result.
You see, I had a varicella, and at 50 years old, I managed to become a dad. Even 8 years on testosterone and HCG, of course.
Oh yeah, you're a perfect example.
But even though I had a varicocele,
Varicocele.
Varicocele, yes.
So there you go. And I have a varicocele as well. So
really?
Yeah.
Even though you had 156 million.
Yeah, well.
I never had more than that.
So
you should become a silent door,
Yeah, I'm curious what they are now, but I've not used HCG now in quite a while. So, any more?
Someone asked, can you ever come off of TRT and
No, you shouldn't.
will your levels return?
No way. Listen, I'll give you an example.
You're good.
5 years ago, an ex-bodybuilder, 50 years old, came to me with 200 nanograms. Okay? He was hypogonadic officially. He got it prescribed by endocrinologist in libido. He started my protocols with enanthate. Okay? Now, meanwhile, he wanted to start competing in cycling, another sport, with testosterone. He was doing superb. But he joined a club, and they told him, no, you cannot go this way. You should come off natty. And he preferred to ruin his health for the sake of the games.
Okay.
Now, 6 months after, it's still zero, his testosterone, and he feels crappy, like an old man. So you cannot restart, and especially when you start testosterone, you're already low. Meanwhile, when you're using testosterone, you suppress this amount that was not sufficient. So you cannot resurrect from the death. It's not something healthy. The only reason you should stop it for a while could be for the sake of erythrocytosis. I tried this during the COVID.
Yeah.
Okay, but I was feeling lousy.
How long did you stop?
1 month only.
Okay.
To drop my hematocrit. I was feeling lousy. My A1C elevated, libido, mood, everything went down, fatigue. Okay, it's like asking, can I stop my T4? No, you cannot, because you don't produce anymore.
No, exactly.
It's not a trendy thing, the TRT. It's a treatment to a disease that has no cure. People should understand this. We don't just start TRT for the fun of it.
No,
This
I
is
know,
not a
I know,
cycle. It's a replacement, meaning that you supplement something that is insufficient.
No, I agree. And I think there is some sexiness about it in the public, partly due to stigma, partly due to just people think the testosterone could be the cure to all their problems. And many times if you have a deficiency in testosterone, yes, it will fix many of those problems. But you know, it's multifactorial. There's many other factors that
It has many health
play.
benefits. We discussed this in Orlando. Doesn't mean that somebody who has a heart failure and takes testosterone will improve. And we shouldn't misjudge and mislead that it's the solution to all your health problems.
No, it's not. But
All
then
right.
having low testosterone
It
won't
doesn't
help
mean
it
if you
either.
die with heart failure, taking testosterone we blame testosterone for this, okay?
Fair enough. What else do you have?
Any advice for hand numbness, especially at night while in Sustanon?
On Sustanon.
Sustanon. By the way, I'm with you guys, and I have had a fantastic service so far.
Oh, thanks. That's great. So, do you have any advice for people that get was it tingling in the hands, numbness in the hands?
If you have numbness, could be carpal tunnel syndrome, okay?
What about if the muscle gets quite big and puts pressure on the nerve as the muscle grows? Sometimes you have
Really?
some tingling. Yeah. Certain mattresses I found will cause my hands to go a little bit numb. I get that sometimes in my hands, just the hands fall
Maybe
asleep.
you think it's vascular or it's neurological
I don't know.
related.
It could be both. Some people will claim some numbness in the hands if they're using too much. Was it B6? Vitamin B6, yeah, because some people use B6 that may cause a little bit of what feels like a neuropathy or some tingling. So, I might suppose book in an appointment with one of the docs, and you know we can have them talk to you about it.
Okay. And thoughts on HCG only cycle for a natural lifter looking for an edge in the gym?
What? Say again.
The way they worded it.
Yeah.
Thoughts on taking HCG?
Yes, you can raise your testosterone, but there's not a reason to.
Yeah, because
go-
if you take the HCG, you're going to shut down your pituitary axis.
Yeah, exactly.
The only saving grace is your testes are still going to be alive. So I think one of the issues is when someone is going on testosterone replacement therapy, or they're doing other forms of testosterone, they end up shutting down not just the brain but also the testes. And then when they stop everything, you're hoping those will all come back on, first the brain, then the testes. But by that time, the testes may have atrophied and they're not working like they should do. If you use HCG only, the saving grace is, okay, you shut down the brain, the testes are still primed. It's like it's like a factory. When if a factory is producing all these widgets, and then the head office shuts down and the factory shuts down, well then it's gonna be really hard to turn everything back on again. But if the factory is still running at a much lower level of production, and just getting the order back on might help. That's a terrible analogy, but it might help improve the testosterone levels on its own. But again, HCG is one of those things that, as an adjunct, if you're using it monotherapy, I don't think it's going to give you the optimal levels that you're expecting, and there still will be a price to pay at the end, right, waiting for your levels to return to normal. The only, like I said, saving grace is your testes will have been exercised, if you will, during that time. But again, you can still upset the whole balance of things.
And can you have kids while on TRT and HCG?
Absolutely,
Yeah,
yes.
Dr. George. Yes, you can.
And
We see
some
many
people-
patients, yeah.
Some people add also HMG, which is even more beneficial, and you can
HMG,
and you can
or recombinant FSH.
it's synthetic FSH. Yeah, you can reverse oligospermia. I've tried it many times.
All right.
And if injections are given at the same frequency of propionate and cypionate,
No,
will they raise E2 at the same rate, or does half-life make a difference?
half-life make a difference, and the sooner the half-life, the less likely to have estrogen because you're using a lesser dose more frequently.
But you'll have a time for clear out as well. So again,
The problem with Cypionate and Enanthate is that if you don't wait until they clear off, then you accumulate the next dose on top of it.
a bit, yeah. And you're going to have
That's
a,
why the perfect microdosing happens with Propionate.
well, look, we've seen some patients that have come to us from elsewhere that were doing 10 milligrams a day of testosterone cypionate, okay? And they had really elevated hematocrit and hemoglobin, and levels were higher than they thought they would be because they're only doing 10 milligrams subcutaneous, which also points to the picture of you can't predict the release of that testosterone as easily as you can with intramuscular, because it's more vascular in the muscle compared to the subcutaneous and fat area. So because of this, when they were switched to testosterone propionate, 25 milligrams every other day.
Yeah, you told me that.
Yeah, they had the hematocrit and hemoglobin normalized. It didn't go to the levels that once were on the cypionate because they had time for it to go up and to clear out. So I think that's better. Was that what the question was?
And John asked, my hematocrit
Hematocrit, yeah.
Hematocrit.
is 57. I feel fine.
How much the hemoglobin? Because, I mean, he doesn't say, but if you are dehydrated, hematocrit elevates. So it's a tricky thing just to focus on hematocrit. You may are dehydrated and the hematocrit should elevates. Anyway, he feels good and?
He feels fine, but he's on TRT and BNH.
And?
BNH.
He's with us.
On the
He's with
hormone,
both hormones, yeah.
Yeah.
We'll have, yeah.
Now, 57 hematocrit, if you're well hydrated, it deals with a hemoglobin of 19, which is elevated. All right, so yes, he should get phlebotomized, use salicylic acid, which is aspirin, hydrate well,
And
prefer the microdosing. And we know that cream elevates to a lesser degree the hematocrit.
to a lesser degree, but in some patients it could still increase it, yeah. It can still increase it. So
Well,
yeah,
it has a logic to that because it's a microdose.
yeah, book an appointment with one of the doctors at BMH and they'll be able to make the adjustments if they haven't already. All right, any more?
We've gotten through all of them so far.
Okay.
Okay, amazing. So, all right, well, look, that was, I think it was good, first go at doing live videos. We hope to have many, many more of these, both live and recorded. I appreciate everyone who participated in the video, and I look forward to doing the next one. So, anyone watching this in the post-production, give a like, subscribe, and yeah, see you next time. So.